Good afternoon, everybody. I'm Laura Siminoff. I'm Dean of the Temple University College of Public Health, and welcome to our conversation today with some prominent regional healthcare leaders concerning how the COVID-19 pandemic has changed healthcare delivery and the patient experience. So, as the healthcare industry adapts to COVID-19, I think we're creating a new normal in terms of how we deliver and experience clinical care. Clinicians are delivering care in new ways, and the patient experience is changing. Much of the change, I think, has been facilitated by technology, specifically telehealth and the electronic health record. Today, I'm pleased to welcome a distinguished panel of medical experts. They're going to discuss these changes and where we're heading with them, and also their personal experiences in delivering care during the pandemic. So joining me today are Dr. Ravi Rajan. He's the chief of the Bucks County Division of New Jersey Urology. He's also the president of the Princeton Physicians Organization, and I'm happy to say a member of the College of Public Health's Board of Visitors. Joining him are Dr. James Nathan Palmar. He's professor of otorhinolaryngology, that's a mouthful, in the Division of Head and Neck Surgery at the Hospital of the University of Pennsylvania. He's also director of the Division of Rhinology and co-director of the Cranial Base Center. Dr. Jennifer Rajan is joining us. She is a board-certified dermatologist. She specializes in all skin conditions, including skin cancer diagnosis, treatment, and cosmetic procedures. And last but not least, Dr. Leonard Malamud. He is the director for the Division of Family Practice at ARIA Jefferson Health. Dr. Malamud practices in Levittown, and he has over 40 years of experience in the medical field. He's graduated from Des Moines University College of Osteopathic Medicine and Surgery Medical School in 1980. And I'm happy to say all of our panelists are Philadelphia Magazine Top Docs in 2020. So, COVID-19 has caused really a major disruption in medical care and services. Patients have shied away from going to their physician offices for routine care, and hospitals shut down elective surgeries and routine screenings. And we're only now just starting to open up here in the Philadelphia region. Now, as the days have turned to weeks, physicians in the healthcare system have sought another way to deliver at least some non-COVID care and turn to telehealth. The ability to seamlessly access patient data, both for individual health, but also for public health purposes as we've tracked the pandemic, has also proven to be, I think, a game changer. All of this is changing the way care is delivered, managed, and experienced by both practitioners and patients. Some of these changes may even become permanent fixtures in our healthcare delivery system. To get started, I'd like to ask each of our panelists to discuss their own experience with telehealth and the health electronic record system, and to comment on the benefits and challenges for you and your patients. So I'd like to first start with Dr. Ravi Rajan to give us some thoughts about this.
Well, telehealth is something my practice had never done before. Our version of telehealth was picking up the phone and talking to patients. It's only when the federal government said that Medicare would be covering telehealth visits did we then say, hey, this is a good way to deliver care, especially when we're trying to limit who's coming to the office. Luckily, our EMR, the existing EMR, already had telehealth. Some states were more liberal, and there were people in our groups who were doing telehealth in New Jersey as it was covered. So we had the infrastructure in place. It was very easy for us to employ telehealth. For the patients, especially the older patients, not so easy. They may not have a smartphone. They're not comfortable clicking on a link or even knowing how to do it. That was a limiting factor. Short of that, telehealth really helped during the crisis. Not everyone could benefit from telehealth, but many could.
Dr. Palmer, what about you? What has your been experience?
So, not as positive as I would like it to be honest. And that has a lot to do with the specialty that I'm in. So otorhinolaryngology, head and neck surgery, or ear, nose, and throat, Our patient experiences really have two pieces. One is the history and discussion of what their problem is and how they got there. And then the second part, the physical, is really looking with the scope into either the ear, eye, ear, nose, or throat. And that is very hard to do on telehealth. There's some attempts to try and create scopes that a patient could put in their nose and then have that projected by telehealth. There's a lot of risks associated with that, as you might imagine, if the patient accidentally puts it in the wrong place and so on. So I don't know how well that's going to grow. That said, we've done really well with telehealth with the first visit. So if a patient would come to see me, say with chronic sinusitis, the first part of that visit is a history and discussion of what they have before we get to the physical part where I would look with the scope. So I can go ahead and do that part over the phone, identify what their problem is, and hopefully triage them to the right person inside my department and get some of the medical treatment going. So it has been helpful for some patients, but it at least as a surgical subspecialist, it's not going to be enough to get where we need to go.
I see. That makes sense. Dr. Jennifer Rajan, you're a dermatologist, and obviously you need to see things. So how's your experience been?
So dermatology is a completely visual specialty, and we were able to use successfully with both Doximity, which is a free to physicians telemedicine app, as well as through our EMR telemedicine capability. The issues with dermatology is a lot of patients they don't have a good resolution on their computer. Mm-hmm. Patients that are older, we would have the medical assistant set up for them to be ready, with enough, we need bright lights, it needs to be focused, but sometimes you really could not tell. And as Dr. Palmer said, I do believe sometimes that helped triaging. I even had one yesterday where each lesion, I was like, I just so pixelated, so blurry. I said, you're going to need to come in and make an appointment, which is fine, because if I would have been able to see, I might have saved her coming in, and you can kind of pick and choose then more safely the patients that need to be seen. But we did see a lot of rashes, helpful for that. And then patients who are on certain medications for chronic conditions like psoriasis or acne, we were able to do a lot of those follow-ups, which are basically medication refills by telehealth.
Okay. And finally, Dr. Melvin, I know you're a primary care physician, and I have to be honest, I actually used telehealth with my primary care physician a month ago, and I thought it worked really quite well. But so I'm curious how you've experienced it.
I work with Jefferson. I work for Jefferson, and that's been a project of theirs for the last number of years, and we've had it in the offices for quite a while. However, it's very difficult to find the time to implement it, and you needed to find exactly the right patient. For us, like everybody else, we started seeing almost everybody with telehealth, and as Dr. Palmer said, and Dr. Rajan said, some patients just need to be seen. So if I have a patient who is having some chest pain, that patient's going to need to be evaluated. I can't do that with telehealth. I can't listen to their heart. It's very difficult to assess the level of edema in somebody's ankles through a computer. On the other hand, if I have somebody who's dealing with anxiety or depression, maybe a wound check, even somebody who's stable with blood pressure, who has a monitor that we've been able to ascertain the accuracy of previously, those people can be at least periodically seen, giving us some latitude in the office, taking some of the pressure off of live visits. It's certainly better than a phone call because you're able to see the general condition of the patient. Mm-hmm. But it's certainly, as you pointed out earlier, with my 40 years of experience, I'm old. And back in those days, we were actually taught that laying on of hands was very, very important. And in addition to the history, between just the physical examination and the history, pretty much you're going to get it right 95+% of the time without any diagnostic testing. So it's been good, but it's going to be challenging going forward. Some of the younger people love it. They love it for a mild illness. They don't want to come into the office. They don't want to sit in the waiting room. And that's helpful. As I said earlier, it was tough to find a place to integrate, to integrate the telehealth visits. However, now that most of our slates have been cleared over the last couple months, we certainly can template it back in and add it in the future. But I anticipate for me, maybe 15 to 20% of my practice at most.
Yeah. So actually, I'd be really curious. So I do think telehealth has its place. And we certainly all delved into it much more than we ever thought. So where would you all see this, if at all, fitting into your practices? Anybody can jump into this.
I'll say for me, if I see a patient, I give the patient medication. I'll give 2 weeks of samples. I think the perfect is you don't have to come back in the office in 2 weeks, or it wouldn't be 2 weeks. I couldn't squeeze them in. But now I'll say, hey, in 2 weeks we'll do a telehealth visit, and let's see what your experience was with the samples, and we can move from there. So I think they're getting better care in that situation. But for the most part, we should see the patients. It's only when the exam isn't important. If we just recently saw them in this sample situation, that it's beneficial.
Mm-hmm. Anyone else have any thoughts?
Well, in my setting, I'm fortunate. I have a very wide referral base because I do revision work from previous surgeries. So I get about an average 100-mile drive to get to me. So as telehealth gets smoother and better, some of those patients in the far rural areas, I am going to try and move to telehealth. But so much of what we need to do is, as everyone here has said, and Dr. Rajan specifically just a moment ago, you've got to see some aspects of pathology to be sure you get them taken care of appropriately. Mm-hmm. So I worry a little bit we're going to get pushed hard by the federal government and insurance companies to do more telehealth, because I think they see that as a potential money saver. Mm-hmm. And I'm worried that we're going to decrease the quality of our care in that when we get pushed that direction.
Yeah. Jennifer, any other thoughts about it?
Yeah, I agree with Dr. Palmer that I do think there's going to be a push towards this, but that does require a lot of, assistance from Medicare and private insurances to ensure that that's a possibility for patients and that they don't become all financially responsible. I do prefer telehealth over a phone call, especially for post-biopsy follow-ups, because just seeing a patient in their house, and especially if it's a patient you've seen for many years, they love it. And many of them have not been out of the house or done much, and it really gives you a nice connection. And it does help you triage patients, as I said before, for the determination if they should come in or really don't need to come in, if it's okay to wait. And, generally, I think that would maybe make up about, at most, maybe 10 to 15% of my practice in a usable way.
Okay. All right. So, I'd like to talk a little bit about personal protective equipment, otherwise known as PPE. So I would make a guess that most Americans have never heard the term PPE. And now, everybody's obsessed with it. At least they were obsessed with it for quite a while. So I'd like to ask a little bit about what we're doing to keep patients and healthcare providers safe, both in inpatient settings and outpatient settings. So let's start with Dr. Malavan. What about the role of PPE moving forward in the outpatient setting? What do you think's on the horizon for that?
I think that for at least the next year, what we're dealing with now is probably our new normal. Once we have a vaccine and can adequately vaccinate the populace, we may see less. And my guess is that even after we don't have to wear masks on a regular basis, my guess is that some people are going to feel more comfortable doing that, and we'll see it in the population much more consistently than we do now. For us in our office, the physicians, the staff, everybody who is patient-facing is wearing masks and face shields. Every office is being wiped down after every patient. We're limiting the amount of people that can come into the office. And currently, there's only one at a time, so there is nobody in the waiting room. We're not practicing social distancing because we're not allowing people to get close enough to each other to do that. That will obviously ease over time as we become a little more comfortable also. And the economics of it are just the realities. And we're not going to be able to continue to exist as a health system or as individual physicians seeing 1 or 2 patients an hour. It's just not going to be economically feasible. For how long this goes, I don't know. This is the one thing we know is we don't know anything. The World Health Organization just told us that if you're asymptomatic, you're unlikely to spread this, but oh, wait a second, that's not really what I meant to say. Everything is changing on a daily basis.
Yeah. Dr. Jennifer Rajan, what about you? I mean, what are you using for PPE these days, and how easy has it been for you all to get what you need?
So it's been a slow process. Our office initially furloughed the vast majority of our employees, which really shrank the number of people in the office at one time. Every person that is working, as well as the patients, are required to wear a mask. Our employees wear masks at all times, even around each other. We have them wear gloves. We try not to have them collect cash or checks. If they do, they collect it into a bag, and preferably have them the patients use a credit card ahead of time for any kind of copay. We like people with long hair who work there to have it tied back, like I have mine every day.
Yeah, mine too. I haven't gotten it cut in months and months.
And we wear face shields. We all wear gowns in the back. That's the medical assistants and physicians in the office. And we wear that over scrubs that we can wash when we go home. And we do the same thing as Dr. Melamed, where we have taken out all except 4 chairs in our waiting rooms, just one against each wall. But the way we've scheduled patients, there's never more than 1 or 2 people. They cannot bring anyone with them unless they're a minor or an individual requiring assistance, like some of our elderly patients. Other than that, they go back to the room alone. And if we sometimes get a little bit behind with patients, they wait in their car, and my office staff will call them or text them when it's time to come in.
Okay. So let's turn to the outpatient setting, and I mean the inpatient setting. And Doctors Palmar, Doctors Ravi, Rajan, can you tell me a little bit about what it's looking like there, inpatient?
I'll start first. I go to 3 hospitals, and initially there was very little PPE. And as time has gone on, some hospitals have more. So, for instance, we were initially told, "Oh, you don't have to wear a mask in the hospital." Then one hospital, which is in Jefferson Northeast, wanted everybody to wear masks, patients, anybody, and any staff who comes in the hospital. And I thought that was a good move. And I would wear my mask, say, to another hospital, and then Sonia would ask me, "Why are you wearing your mask here?" So there was mixed signals initially. Very soon, all facilities followed suit, and everybody's wearing a mask. As far as the N95 masks, they were in very short supply. Initially, we had to wear them for at least, say, five, or I won't say it, the most for 5 days, and then we can get a new one. That has loosened up. Most of the hospitals have plenty of N95. I feel more comfortable wearing a new one, especially in surgery, than reusing it. So with time, I think the PPE for the hospitals will improve. As far as my office, our staff just wears what they can buy. We don't have PPE in our office. I would like N95 for all my staff, but we don't have access at this point.
Dr. Palmer?
So we were fortunate because we were a big closed health system. So at Penn, we could make individual moves and the whole group would do it at once. So very early on, we went to everyone had to have a mask when they came in. To get into the system itself, you've got to get your temperature checked. You've got to wash your hands. You got to do all these things to help improve it. And I have 2 lives. One is the OR, and then one is the office. In the OR, everyone's got to be tested before they get put to sleep. And so the biggest risk for us as otolaryngologists, especially as a sinus surgeon, is that that's ENT and ophthalmology were the two groups that got hit the hardest in China, because you get coughed, you get sneezed on, and you get infected. And there were in excess of 100 ENTs that died in China, I believe. I don't know exact numbers here because so much stuff is being passed through a rumor mill or an attempt, and we don't know correct answers. There was a story of a patient that came in to get a pituitary surgery done. Didn't know if he was positive, the patient was positive or negative, and supposedly all 14 members of the surgical team that came in and out of the OR, surgeon, anesthesiologist, nurses, everyone were infected. So that created a huge amount of fear. And the N95 masks, small numbers, so they were being reused like Dr. Rajan talked about. But now that testing's getting better, we're on the way to getting back to our normal, where we go ahead and make sure you have a COVID test beforehand. And if that's negative, then you only have to worry about the low level false positives. I've changed my surgeries a little bit. But the big change is the office for me, because when I'm looking in the nose with the scope, I'm still creating potential aerosolization and passing the virus around if the person is positive, is infected. And so testing all those patients before they even get seen for one visit is obviously not something we're capable of doing yet. So we have a second set of screening to check on those patients. I'm having them irrigate with, of all things, baby shampoo, which kills the virus, and they're washing out their nose before we look, and then using a lot of PPE. And it's going to be a process. One of the things I keep telling my patients, and mirror what Dr. Mahmood said, was this is the new normal. Things have changed, and Ravi, Jen, and I all started medical school right when HIV became very big, and it changed universal precautions. We didn't know what they were when we started, and then all of a sudden we had to be sure we were gloved and masked and so on. That's what's going to happen to us now. Another thing I point out to patients is when they come into surgery, usually lots of family members would come with them and wait in the waiting room and be there to talk to us after the surgery. And I tell them, it's a little bit like flying after 9/11. Before 9/11, you thought it was important to go with your family member all the way to the gate, wave goodbye to them when they got on the plane, and then that was normal. Now you drop them off at security and you don't go in any further, and you wave at security. And I
That's
tell
a great analogy.
yeah,
It really is.
I tell the patient families that we're going to do the exact same thing whether you're here or not. I'm sorry, but you're going to have to drop them off at the curb, and the family member will come in and we'll do a good job and take care of them, and then take them back the other way so we can decrease our exposures. And I don't think that's going to change. Even with the vaccine, even with all the things that we want our pharmaceutical companies to do and all the wonderful things that American and world medicine will bring us, I think we're going to have to make those changes.
So you think even if we get a vaccine, we're still going to have to do that?
I think I do think we're going to change the way we do families coming into the hospital and so on, just to frankly decrease those numbers of possible infections. And I think that may make us be better long-term in medicine anyway. If you think about it, all those patient families coming through the hospital, while being very important on the emotional side for the patients that were there, we're probably potentially passing infectious diseases and exposing them to hospital-acquired infections and a lot of things that we're probably better off being away from on the purely empiric medicine part, not the emotional part, which is obviously very important. And we're going to have to figure out how to work with that. Maybe we'll be FaceTiming patients when they're in the hospital so they can see their family members. We've already done a lot of that. And I worry about the HIPAA rules, the privacy rules, because, up until very recently, I couldn't FaceTime with a patient without that supposedly being able to be discovered and all sorts of problems. And the patients would say, I don't mind, Dr. Palmer. I want to talk to you. I'm not worried about people knowing that I have chronic sinusitis. My whole family knows this. And so we've got to figure out a way to work ourselves through that system, because patients in the hospital after their surgery, they need to come for their family members. And FaceTime is not as good as someone being there, but it's far better than nothing.
Right. So you mentioned testing, and actually, I really do want to talk with all of you about testing. I think as a public health professional, testing has been the 800-pound gorilla in the room. So testing is highly variable across the country. In New York State, it's become pretty easy to get tested. I'm not sure about New Jersey, but I still think that testing in Pennsylvania leaves a lot to be desired. So, Dr. Malamud, you've had some experience with outpatient testing, and I'm wondering if you could talk a little bit about that experience. I think you were testing in like one of those outdoor parking lot kind of things.
Yeah, we had actually with Jefferson, we had one center in Bucks County and we had one center in Montgomery County. And in Bucks County, we were set up on Street Road across the street from Park Casino and running probably somewhere between 125 to 150 patients a day through the tent. That has gone over time. There's less of the general population, and as we ramp up now for our outpatient surgeries, we're running a lot of our pre-admission screenings through there also. So those numbers are going up, and the total numbers being screened are going up. We've had that probably for about 2 months now, and I'm trying to remember the exact number. I think we've screened about 15,000 people through those doors. We also, at the same time, recognized that while we were doing telehealth, we were unable to really bring anybody who was ill with any kind of respiratory illness into our offices. So we established a respiratory screening center that after doing a telehealth visit with the physician, if they felt this was somebody who needed to be fully examined, we would send them over to the respiratory center where they could also be screened for COVID, as well as get an examination from physicians who were in full PPE, gown, gloves, mask, shields, etc.
So where do you all think testing needs to be, and where we are? And how do you think we're going to get there?
Is that a question for me?
Anybody?
I think the accuracy of testing, I know that the actual swab is difficult to perfect because it's an uncomfortable test and it can sometimes be user dependent, but the fact that there's, a considerable number of people that can falsely test negative, I think doesn't give you full comfort seeing them for, an invasive procedure as, Dr. Palmar would have to do. For my practice, cosmetics, we are not comfortable doing anywhere in that area. I would not feel comfortable with the test being negative one time.
Ravi, what do you think?
I agree. The false negative is the biggest bane of getting this COVID under better control. So until we get better testing, it will be difficult. We know if somebody's positive, we can rely on that test, but if they're negative, it's hard to rely on it. As far as accessibility of testing, if I want to get a patient tested, it's very easy to write a prescription and have it tested. As far as I know, it's being covered by the insurance companies at no cost to the patients. That's what the patients have questions about also. So we need to test more and test more often.
Dr. Palmer?
We've got to move to some sort of home test also. And the reason why is that while we're doing okay with testing with people that are sick or pre-op, but there's a whole nother space in there, especially with allergy season, colds, and so on, that I would love to see us be able to get. You stop by the Walgreens or the CVS and pick up a home test and do it. And that will make a huge difference, because there's a lot of people that I believe that are home and scared and don't even want to go to a testing center to get tested. And when you talk about numbers, I mean, it's almost, if we really wanted to break the back of this pandemic, we would put a test in everybody's hand, and at noon on one day, everyone would test themselves, and we'd know where it is and where it's not, and then be able to move on and do what I wish we could have done at
An
the beginning.
epidemiologist's dream.
Right.
Right.
I recognize it's a impossibility, but for a country that can do the incredible things we can, I think we can get a heck of a lot closer to that.
So, one of the things we talked about at the very beginning was, health IT. And, I mean, we've made tremendous progress over the past, even just several years. And so I think that definitely monitoring the infection, understanding where there are outbreaks, this has been really beneficial. It seems like it's also been beneficial when we've had to work remotely. So where do you think this needs to go? I mean, where should we be going, and how connected should all of our data be between health systems and then feeding into local, state, and federal government?
So I've been consistently frustrated with the IT systems. And it's because I occupy a slightly privileged spot in that I'm inside a health system. So a patient that comes to me that's inside Penn's health system, it's fantastic. It's got all of their primary care, it's got all their cardiology, it's got everybody in there. Except that realistically, that's 15 to 20% of the population that I see, and 80% is from another health system or somewhere else. And the systems simply don't talk to each other. And this is a massive mistake and failing of our system. Why are we setting up silo after silo after silo and spending literally billions of dollars when, if the systems would talk to each other, so many issues would go away? And that's in the day-to-day care of the patients, let alone the COVID epidemic. I think we could have tracked where people were going. We would have understood the disease quicker, faster, and been able to get help to people. And I'm consistently amazed at how we don't make these big picture moves for the health of our country.
Dr. Melnick, you're in primary care, and so you see everything. What do you think? How's your experience been?
You're muted.
You're muted.
It sounds much better that way. Is that specifically with the IT? Is that what we're addressing there?
Right.
Dr. Palmer is absolutely right. When, again, I'm going to go back to Jefferson, when we merged with the Kennedy system over in New Jersey, we had Kennedy with one system, Jefferson Center City with another, Abington with a third, and the ARIA division with a fourth. Come where are we now? Maybe 8 months from now, we should all be on Epic, so we can see everything that Dr. Palmer will be doing. So you better be good, we're watching. There are a number of health systems that have gone the Epic way, and I believe Temple is also another one of them. So
Yes.
in the city of Philadelphia, while it is still fragmented, the net is being cast a little bit wider. And I think that will help with communication. I think that will help with testing. We won't be duplicating tests that have already been performed on somebody else. Somebody who was in Temple's emergency room yesterday and had a CAT scan won't end up in our emergency room tomorrow and get another CAT scan for the same complaint. It is, the IT aspect of this is frustrating. I'd rather have pencil and paper, but that is not the way of the world anymore. Again, I'm old.
Dr. Rajan, I know you've always been a real proponent and excited about the potential of IT. How do you feel? How's your experience been?
We have to balance patient privacy with accessibility, and that's a juggling act. But I think we are failing, just like Dr. Palmer said. Tests are being repeated. If we want test results, I have someone in my office, and they had seen Dr. Malamud. we have to fax or somehow get the test results. Otherwise, their appointment may be wasted. So this interoperability is really the phase that will make American healthcare.
Can you
as
define interoperability for some of our listeners who
I think what that
may be
means is,
unfamiliar?
I'm sorry, I think it's data. Or if Dr. Malamud ordered some lab tests, I'll be able to see it. If Dr. Palmer did surgery on a patient who's now in my office, I'll know what the person did. We can rely on the patients telling us, but they won't know their lab work, and they may not know exactly what Dr. Palmer did. And sometimes they'll say they're sure about something, and when we look at the record, that's not what it shows. So we really need to be able to see the patient's whole health record, and it is fragmented now. And the Epic system is taking over the country. My practice will be implementing Epic in the next year, so that will make it nicer. But it's an expensive system, especially for private physicians. Health systems can absorb the cost much more than the independent physician. Well, just segue a little bit. As far as IT is concerned, I think a great place is in the nursing homes. What I did see with COVID is that we were doing the telehealth visits for the patients in the nursing home. The registered nurse would get on the call. The patient would be there, and we'd have a three-way conversation. The way it works when the nursing home patient comes to my office is they'll come in. Frequently, they have dementia. They don't know why they're here. I don't know why they're in the office, and I don't get a full history. So I think in situations such as a nursing home, we need better IT infrastructure, and we can really improve their care, especially specialist care. Not many specialists will go to nursing homes.
And if I may add, Ravi, taking it in the reverse, there are many times that I refer a patient to a specialist, and when the patient gets to the specialist, despite my efforts to have informed the specialty why the patient is coming, the question is, well, why are you here today? And the patient says, I don't know, Dr. Malamud sent me. So if we're working all off of the same system, or at least systems that can speak with each other, the specialist now has access to the complete chart, can see the rationale, can see the testing that's been done, and makes their job a little easier. And with the telehealth component of this, as you were saying for nursing homes, that also allows us, we use the Teledoc platform. I don't know what anybody else uses, but that allows us to invite other participants into the office visit with the permission of the patient. So you can now have children who are living in other states who now know what dad found out when he went to the doctor, what he was told to do, instead of the doctor saying, they told me everything's fine.
Have any of you used telehealth to do more team medicine, to do case conferencing, bring in several specialists with a particularly complicated patient at once so that you can all work together, as opposed to, the patient goes from one to the next, to the next, to the next?
So we've actually created, we have a Cranial Base weekly conference, and our tumor board has now gone virtual, and it's actually worked better than all of us in a room, because when you're trying to get everybody into the room, someone's got surgery, someone's got their clinic, so on and so forth. But with this virtual ability, everyone clicks into their Zoom meeting at that time, and we present all the patients, and you can get 10 opinions right there at one time. Admittedly, the patient isn't there. We're going from their data, but it's worked better than personal conferences have. And I suspect we're actually going to change the way we do our tumor boards and our cranial base conferences to that direction and keep it that way.
So I think, I'd like all of you to weigh in on this. I think that there's been a lot of really interesting things that have happened as a result of the pandemic, and frankly are going to continue to happen. So what do you think are things that you would retain and about how you've changed your practice? And then conversely, what are things that you'd really like to ditch and go back to the way things were? Jennifer, Rajan, Dr. Rajan, what do you think? Oh, you need to
You're muted.
unmute.
One of the things I would love to ditch is just how much I guess, surveillance we have to do of patients with all the quizzing about, fevers, have they been around someone recently, what they have to do when they come to the office. I mean, it's a lot of preparation to keep both the patient safe, but also the staff and the physicians safe in the office. It'd be nice if there were just standards of care that people could assume on their own without our staff having to remind them. And now we're setting up a text messaging system so the night before, it could remind them again, you need to not have been sick and you need to come in with a mask and don't bring someone with you unless, it's absolutely necessary. So those are things that I could definitely leave behind. I think things that are good is it's a healthier way, like Jim was talking about with, treating every patient like they have, HIV or hepatitis C. We've learned to do that with procedures because you never know if you treat everyone like that way, you're going to keep everyone the safest. And same thing with these airborne diseases. It's going to help us not just for COVID, but even reducing things like influenza, other common cold communicable diseases that certainly can make people very ill, as well as put them out of work or out of commission.
Other people's thoughts about, what you would keep, what you would hope that would go away?
I would keep the mask to a certain degree. If somebody has a cold, no, we rarely saw somebody wear a mask, but now I hope it is that way, and it will improve everybody's health aside from COVID. So wearing the mask, I can't wait until the family members can come back into the office. A lot of the patients maybe won't remember exactly what I said. It's good to have a second set of ears listening to what I say. The family members enjoy coming with their family, but right now it's a little bit risky for them. But those are the two things I want to stay in and also want to change.
How do you think the patients have been experiencing this? How have you tried to give them as good an experience as possible through all this?
For me, the one thing that I missed the most, to echo what Len said, was the laying on of hands, the touching, shaking hands, patting them on the shoulder. A lot of that physical touch is gone. And now I come in and I stick my elbow out and they stick their elbow out. We do a virtual elbow bump. And it's just not the same. And I really miss that. And I think patients really miss that too. But I do think, I think Jennifer said it best when we've just got, in the same way we learn to be different with bloodborne illnesses, we need to learn to be different with respiratory illnesses. Mm-hmm. This will probably help us long term.
Dr. Melvin, any thoughts for you?
I think that the world we're moving to is a hybrid with what we have now and what we had once. As Dr. Palmer said, the thing that I missed, I'm in family practice, so I've been taking care of the same people for going on 40 years. They're now in their 70s and 80s, and they were in their 30s and 40s when I started taking care of them. And it's a very personal type of event when they come to the office. It's somewhat social. And while the telehealth, I think, is good for certain types of visits, as I said before, and I look forward to keeping those, I think it does take the humanity out of the visit to some extent. And one of the things that I miss is, as Dr. Palmer also said, is the ability to just shake somebody's hand or put my hand on their shoulder as I'm talking to them. Mm-hmm. If you're breaking bad news, the inability to have any physical contact with that patient is very difficult. So I'm looking very much forward to reaching a time when we can at least be better than we are now as far as our ability to connect and touch other people.
Okay. So I want to ask you all a final wrap-up question, but I want to tell the audience that you can ask a question. There's a Q&A function on Zoom, and so please feel free to type your questions in, and we'll answer in just a few minutes. So my last question to all of you is like where we are now in terms of we are opening up. slowly. Are you taking patients, non-urgent patients, patients for regular care, screening? And if so, are you having to, is there like a flood of patients wanting to come in? Are you needing to prioritize who you see? So what's happening for each of you? And we can kind of go around and everybody can answer whoever wants to start.
I'll start.
Okay.
I've never stopped seeing patients. There are patients who are not acute that I've always brought into the office, not necessarily because, again, they were acute at the time, but somebody who just needed to be seen, somebody who has a history of going bad, somebody who you just need to keep stable and prevent them from needing to go to the hospital, especially in times like these when you really don't want anyone in the hospital. I'm bringing in physicals that need to be done, the annual well visits for some of my elderly Medicare patients to make sure that they're keeping up with all of their wellness. We're overlooking a lot of our preventative measures recently, or at least kicking that can down the road. And unfortunately, by delaying mammograms, colonoscopies, we're going to run into areas where pathology has progressed and we lost the ability to catch it at an early stage. So yes, I've extended my hours to bring more people in because we are able to see less people per hour or per shift. So I've expanded my hours in order to get people in the door. But as I said before, I think telehealth will be important, but I think getting them in faster, more, sooner is better.
Okay. Dr. Raja? Ravi Raja?
My office, just like Dr. Malamad's, we were open. Our whole focus was keeping people out of the ER. So if it was for kidney stones or bladder infection, and we had patients for cancer care, we wanted to see them. So we tried our best to see everybody. What we were eliminating were, say, vasectomies, that type of stuff. But if a patient calls with a question, it's very hard to know whether or do they really have something wrong or not. We can use telehealth, but there's nothing better, at least for me, to come and examine them, check in the urine. So we did not stop. And I think it was good. I would just segue. When I walk in the hospitals, the ERs were empty. And the ER docs in different places would say, where is the appendicitis, the pneumonias, the heart attacks? These ailments that were filling the ER weren't there, and we can't make appendicitis disappear. Only, I think, in 5 years, we'll look back and we'll know exactly what happened. And as Dr. Malamud said, we'll also see if our cancer rates of, say, morbidity or mortality will go up because of people not seeking care during this time.
Mm-hmm. Dr. Rajan? Jennifer?
Okay, so during the initial days after the whole COVID epidemic, we continued to see patients, but we pushed off everyone who was not acute and only saw acute things for the same reason as been stated, to keep patients out of the urgent care, out of the emergency rooms. We saw a lot of infections, bad rashes, a lot of bleeding lesions. Not sure why the patient had waited that long to be seen, but very urgent things. And after about a month, of course, all those patients you've put off are coming back on your schedule. And, it's not, you can't know if a melanoma follow-up, if it's okay to push it off another 2 months, or if what someone is coming in for is urgent or not, because telemedicine can never take the place of seeing the patient in person.
Mm-hmm.
And, I think that's really important. So we started seeing patients if they felt they needed to be seen, and that's what we're currently doing. And oftentimes patients do come in, and I think, that probably could have waited 6 months or a year, but truly it couldn't, because I don't expect the patient to know what their condition is or if it's something urgent or not urgent. And that's the point of seeing the patient. And I imagine we'll continue to do that for the near future, and seeing future patients like Len said, you start pushing out your hours a little bit just to make sure that you don't overlap with patients, and we'll have to see how that works long term.
So for us at Penn, it's been a pretty fascinating, whether we like it or not, process. So my life has two parts. One is chronic sinusitis, which is to some extent a lifestyle disease, and the other part is sinus tumors, which clearly is not. So, and almost all of us had some type of division in what we did. So we just moved to just doing the cancer, just the acute, the things that had to be done. And now we're opening up and doing those other parts. And the interesting message that I've had to get out to a lot of my patients is it's probably about the same safety as going to the grocery store now. Because I think people say, hey, all the COVID patients are going to be in the hospital and the healthcare providers area. I don't want to go there and get sick. And there's some truth to that, especially in the early days when we didn't have as good a testing as we wanted to, that those fears might have been real. And now, because we've got the ability to test better, to clean, to do the social distancing, to decrease the number of volume of patients, to only have a certain number of people in the elevators, and all those other things, we've brought our risk dramatically down. And some patients aren't ready to come back yet. And I understand that. And so I do think I like analogies, and my comparison is to back in the day when I used to work at the VA. Every about Christmas time or so, all the vets would stop showing up when the winter got cold, and they'd stay home until it came into March or April. The weather would warm up, and then they would start coming back. And I think that there's a little bit of similarity to that. And I think patients are going to start coming back now that they know things are safe. We've got things arranged better now, and we're ready. I don't know how many people are going to suffer because of that. There's going to be some, clearly, that we would have taken care of, as Ravi mentioned, the appendicitis and so on. Where were those? How many of them got better on their own? Not that necessarily can get better on its own, and how many of them are now far worse because of that. And I worry about those people.
So if you were communicating to the general public, and we have quite a number of people who see these videos and they're not healthcare practitioners, would you urge them to go ahead and get their yearly mammogram, do all of the preventive screening tests that they've been scheduled to do but have maybe delayed, put off, canceled over the last several months?
Well, I'd give them the advice that I give my parents. They're in their 80s and they've been home and they've been locked in, and they followed their son's directions of stay home and don't do that. And now my dad needs to get his ophthalmology appointment. My mom needs they need to get back to that. And I said, okay, so now we know what you need to do. I sent them masks. They've got masks. They've got their hand sanitizer. They're going to make an early appointment. They're going to show up. They're going to park. They're going to go in. They're going to do all their PPE. They know what PPE stands for now too, right? And the physician offices are ready for them. And then we'll get them in, get done, get them back out. And I think the time it's, your physician appointments are a little bit like going to the grocery store. You need to eat. You need to see your doctor. So it's time to start not putting that off. It's time to get back to that, taking care of yourself. That's now a part of taking care of yourself, just like staying home was in the early days of the pandemic.
Oh, that's a great message. Other people want to chime in on that?
I think, patients a lot of times come in and some patients are not scared at all, and some patients are very fearful. But I think they have to realize that we're scared too. And, we're in those rooms seeing the patients. I'm often very close to someone's face, and it's a little bit nerve-wracking. And, so I think the warnings to, make sure that they're not coming in if they've been exposed or if they're sick in any way. Like they might have gone in the past if they had a cold to the office. Well, put it off if you can, if it's not something acute, a couple of weeks, or get a telemedicine appointment. And all that is true because we're in it as well. We are at risk like they are, and just, as nervous about getting sick and trying to protect ourselves and our staff and help our patients.
Any other thoughts before I go to a few questions?
Sure. I think that, go ahead, Ravi.
This pandemic is not going to leave us soon in the Philadelphia area. I think it is safe now for people to see their healthcare providers, their physicians. So yeah, I would recommend now returning to screening and regular checkups.
I agree wholeheartedly. I think that we are probably the safest place. A physician's office is the safest place to be, based on the decreasing amounts of patients we allow in the office, the excessive cleaning that we do, I should say obsessive cleaning that we do. And what are you laughing at there, Dr. Palmer? And the protective equipment that we wear. It's time to get back. I think right now, at least with my office, most patients want to be back in the office. All along, they thanked us for being there when we did see them. And there are some people that just are very nervous about coming out yet, but I think the greatest majority are happy to come out and actually get examined.
Okay. Well, I mean, I think those are really great messages, and I think comforting to people. So I have just a few questions that I'll read you that people sent in. One of them was, are the changes implemented because of COVID sustainable by healthcare practices? I think that's an excellent question. Anyone feel free to chime in?
The reason why you hear me sigh before I started to answer it is that it's not whether they can be, they have to be.
Right.
And we as a society have to make the changes, whether it be in reimbursement, whether it be in industrial production, to do this, to keep all of us safe. One thing that this pandemic has taught us is we're all in this together, and we need to act that way and help each other along to get there. And yes, we probably will spend more money on healthcare than we did before, but my goodness, it's money well spent. We're taking care of each other. Isn't that what we want to be able to do? So I think those changes are going to be here to stay, and we're better on a lot of fronts because of that.
Okay.
And I think, echoing Dr. Palmer, redundancy in the healthcare system is good. If we had more masks than we ever needed, then we wouldn't have had this PPE problem. The problem is redundancy is also expensive. Why spend more money for masks than you need? So I think we have to shift from trying to be as economically, feasible as possible to having the redundancy. And we should have masks that are made in this country, but also made elsewhere, just in case we have production problems here. But we need that redundancy to protect the healthcare people and also our patients.
Mm-hmm. Okay, another interesting question is, do you feel patients are more interactive with telehealth? Do you feel like your questioning is changing when you have these kinds of visits?
I think my old patients are equally or more interactive because they want to show off their house to Dr. Palmer, and next thing you know, a grandchild's running through and I'm waving to them and so on. And then the new patients aren't sure what to do yet. So there is something about that first visit, that interaction, that is so nice to be in person as opposed to on a video camera. But we're changing as physicians and as people too, and learning how to do this. And we're better at it every day.
Mm-hmm. Yeah, so somebody asked whether or not you know anything or have seen any data on patient satisfaction trends. Or if you haven't, right, we are a college of public health, people ask questions like that. Or if you haven't seen it, do you have any impressions in your interactions with your patients?
I do. Go ahead, Jen.
Okay. Yeah, I mean, I think patients are very appreciative when they come to the office, especially the very fearful ones, and they see all the measures, that we're taking, cleaning the rooms with these viral wipes, and everyone's masked and gloved, and we've wiped down everything we use between patients, and they're one at a time. And I think the analogy of the grocery store, they realize it's cleaner and it's safer, and they can get over their fear. And I think most patients are very happy with that. And same thing with the telehealth. Even the times it isn't really useful because whatever I'm trying to see is just not visible. People enjoy inviting you into their lives, and they're stuck at home, and it's a friendly face, and you're there to kind of help them, or at least give them advice of some sort. And I think patients in general are actually delighted with that portion of
Mhm. Dr. Melvin?
And I'll agree. To me, I think it's probably about 75-25. There are some patients that just absolutely want to be in the office. They want to be seen. And those that aren't being seen right now live, most of them understand the rationale for it, and they think that the technology is interesting, but they're looking forward to coming back. So they're content, but they'd rather be back at the office.
Mhm.
Some of the younger people, we tend to run, at least I tend to run much more closely on time with the telehealth visits than I do live, because patients are less likely to interject 4 or 5 additional complaints during that visit. So they like being able to just pop on the screen. They're watching TV, pop the TV off, pop the computer on for 15 minutes. We do our visit, and then they're right back to it. So they kind of like that without having to come to the office, miss dinner, sit in the waiting room for half an hour, get seen, go back home. It's kind of like us doing this Zoom meeting instead of having to drive to one.
Well, just like the chatty patient, we're a little over time now. So I really want to thank all of you. This has been very, very interesting, and I think incredibly informative. So thank you so much for participating. And if people are interested, they can go to our website, which is shown here, and you'll be able to see probably next week the recording of this conversation, but also some previous conversations we've had. So thank you very much.